are in the live. Start, sir.
Thank you. Good evening, everybody. On behalf of Hetero Healthcare, I extend a warm welcome to all the participants for today's panel discussion on INSTIs ground realities. And today we have with us some eminent experts of HIV/AIDS management to share their experience and views on integrase inhibitors. In the last couple of years, if you see, integrase inhibitors have gained immense acceptance in the management of HIV/AIDS. Various national guidelines have prioritized the use of integrase inhibitor-based regimen for treatment-naive patients. In most of the developing countries, the national programs have moved towards rolling out integrase inhibitor-based regimen in their national programs. Even if you look at the Indian program, ART program, I think NACO has introduced rolling out DTG-based regimen for our population. Currently, I think they have rolled it primarily for the new patients, but down the line, I think they have planned to make it a part of treatment regimen for the patients who are currently on first-line treatment. So a lot of hype is going around integrase inhibitor regimen because primarily because of their safety, efficacy, or ease of dosing, and it has become one of the pivotal regimens for the treatment of HIV/AIDS management. I think with this changing scenario, it is imminent for the HIV practitioners to understand the ground integrase inhibitor-based regimens. And for that, today we have the HIV experts who have seen the transformation of HIV/AIDS in India, right from the first case that has been detected in India to the current effective treatment regimens, which has been expanded and helped in increasing the life of HIV positive people in India. So they're going to share their experience in terms of how exactly things are shaping up, and in the last 3-4 years, what is their experience in terms of integrase inhibitor regimens. And for us today, Dr. D.G. Saple, who is going to be moderating the entire panel discussion. So with this, I'll give a brief introduction about our moderator, Dr. D.G. Saple. Can I have the slide, please? So Professor Dr. D.G. Saple is a fellow of Johns Hopkins University, Bloomberg, USA. He was honorable professor and head dermatology, venerology, and leprology, Grant Medical College and Sir J.J. Group of Hospitals, Mumbai. He is a consultant in dermatology, leprology, and HIV/AIDS, Bridge Candy Hospitals, SL Rahej Hospitals, and Fortis Hospitals, Mumbai. To his credit, there are more than 40 peer-reviewed publications, and he has authored various chapters both in HIV and dermatology. He has published more than 55 international papers and delivered more than 1,000 lectures in India and abroad. He's been a teacher for many people who have their practice in dermatology and HIV/AIDS. He has been conferred with awards such as Lifetime Achievement Award by IMA Mumbai, Lifetime Achievement IADBL Maharashtra, Best Practitioner by National and International Conference of Dermatology 2019. He's been felicitated for IADBL Fellowship Program Dermacon Pune 2020, and he's the first dermatologist to start fluconazole daily therapy in dermatophytosis. So he's been a pioneer, and he's been a dedicated clinician for both dermatology as well as venerology and other infectious diseases. With this, I would like to call upon Dr. D.G. Saple to moderate the panel discussion. Welcome, sir.
Thank you, Mr. Nehru, and thanks for giving me this opportunity to moderate this session. Flow of this session will be, I'll be giving the introduction for 10 to 15 minutes about the subject. After that, we'll have panel discussion. We have the panelists, and after panel discussion, we'll get some questions from the audience. and after that will be closing remarks. So can I have slide of the first panelist? Yeah. Yeah. We have Dr. Sanjay Pujari from Pune. He is a director and chief consultant at the Institute of Infectious Diseases, Pune, a postgraduate in internal medicine, practicing for last 25 years, is principal investigator at Pune site for Treat Asia HIV Observational Database, and he is involved in training physicians globally, including faculty at the European AIDS Clinical Society, and has published numerous papers. So we'll have Dr. Sanjay Pujari, who has got very large experience in treating patients. We'll go for the next panelist. Yeah. Yeah. Next slide, please. Yeah. We have Dr. Ishwar Gilada from Mumbai, who is known for since inception that he is involved in the HIV/AIDS management from the beginning. And as far awareness program is concerned, I think he is on in forefront all the time. He's consultant in HIV/AIDS and STDs, Unison Medicare and Research Center, President's AIDS Society of India, Governing Council member of International AIDS Society. And there are many things, but he has also got large experience. So we'll go for the next panelist. Dr. Dinakar from Hyderabad. Dinakar is known for his clinical acumen. He is a chief consultant physician in Sunshine Hospital, Hyderabad. He is principal investigator in several HIV trials, field research in HIV and metabolic syndrome, now pioneering in telemedicine consultant for HIV patients, and he has finished a postgraduate from Chandigarh. Next slide, please. Yeah, next slide. Our last panelist is Dr. Ambrose Pradeep from Chennai. He is Chief Medical Officer and he is an active researcher in the field of HIV medicine, Fogarty International Clinical Research Fellow at Brown University, key interest in HIV and SCV, co-infection and HIV immunology. He is a principal investigator and study physician for many clinical research and collaboration with International AIDS Vaccine Initiative, Indian Council of Medical Research, and so on. So we have good combination of panelists, which from the inception, middle order, and the younger one. So it's a very good combination. So can I? So we'll start my talk. So can I share my slide, Bharat? Yeah. Slideshow from current slide. Why it is not going to slideshow? I'm not able to go for slideshow. What is the? Can Bharat help me?
You need to press the share button in the right bottom, sir.
Where is that?
Usually it's in the
okay.
right bottom.
Yeah, now it's okay, na?
No, sir, we can't see the screen.
Oh, you cannot see.
Right bottom, you'll see one share your screen. Usually it's in blue.
It's a blue that is with two new notifications.
Usually at the bottom of the screen, sir.
Yeah, but I'm not able to see.
Maybe if you exit the full screen, you will see it, sir.
It is showing that he cannot start screen share.
Oh,
Somebody is sharing this. Other people are sharing, so I cannot start. That's why it says.
then the host has to probably project your slides.
Yeah, Pradeep. What is happening? I'm not able to come out of it. Hello?
There must be a share screen.
Yeah, but it is
icon,
showing that somebody else is sharing.
Yeah,
now we
it's
can
come.
see it, sir.
Now it's
Well,
come.
Yeah. Now you will have to just click on your slideshow and then
where
to
I have to
full
click? Where I have to click?
Where is the presentation, sir?
Yeah, but presentation, I open it, I'm not able to see. I think I'll go back. But yeah, I leave and join again. That will be better, I think. Can I open my slide now? Hello, Pradeep.
Yeah, I think it's the same.
Now it will happen.
Yeah, it's open, sir.
Yeah,
getting that blue but it's okay. We can read through it.
yeah, it's okay. Yeah, yeah. We have gone through introduction. Yeah, I thought before just going for this Insta, I will just give, of course, all of us, we know what is the goals of this antiretroviral therapy. That is the suppression of HIV RNA, then preservation of restoration and preservation of immune function, reduction of HIV-associated morbidity and mortality, prolong of the duration and the quality of survival. These are then, of course, and maintain the copies below 20 to 50 per ml. Talking about survival rate now, of course, initially in 95, the most common cause of death in USA was HIV, but now you see it has become the least cause. about the survival. Now we are surviving more than 60 years. So it has become like any other immunocompetent patients. But today we want to end the epidemics. To end this epidemic, what we require is the control of HIV. And as we do not have vaccine, we have to see that most of our patients will remain on ART, will remain in ART, retention in ART, and will have undetectable viral load so we can achieve. And for that, they call is the formula of 90, 90, and 90. So achieve this or to end this HIV epidemic, we have the new strategy of adherence, individualization, rapid initiation. Think of MDR HIV like a MDR TB, dual therapy, Swiss therapy, CROI outcome, and the COVID and HIV now. So there are new drugs. Most of the new drugs that have come, they work on the reservoir more than the multiplying these HIV virus like capsid inhibitors, latency reserve agents. So new drugs are coming for the reservoir. Talking about the adherence, they say those people who got poor adherence, better to use high generic barrier to prevent resistance, and not only the prevent resistance, the person will have less viral load so that less transmission. So this is one of the study. This is GS1489. They compared with the bictegravir and dolutegravir, and they found that result is more than almost 90%. So adherence is very good. Talking of the individualization, because we just cannot go by the factors, but we have to consider the patient factors, which are the drugs is acceptable and affordable to the patient. Then coming to rapid initiation, they start test and start the treatment or start the treatment on the same day. There, according to study, they said if you start the treatment initiation, rapid initiation, there is increasingly likelihood of ARD initiation. More patient will be retained in the ART care. There will be more patient of viral suppression compared to standard care. They are likely to, there will be more dropout. There will be a lot of patient who will be lost to the follow-up, and there will be more morbidity and mortality. So this rapid initiation, now it has been well accepted. And when you are doing rapid initiation, only thing they say, start ART when the patients are ready. Do not just start because as a clinician we want to start. If the patient is not ready, better to avoid. And before starting, rule out underlying OI, especially in our country, tuberculosis, where we can avoid iris. Then talking about this MDR HIV, like a MDR TB, even it is in a small quantity, but still MDR HIV remains quite relevant. We know what are the causes, non-adherence, resistance, or the primary resistant transmission. Then there are new drugs coming for this MDR HIV, fostemsavir, ibalizumab, or the Pro 140. Ibalizumab is one of the biologicals. Now biologicals are everywhere in each and every faculty, whether it's a rheumatology, whether it's a dermatology, the ophthalm, mostly they are used for the autoimmune disease, where there are anti-CD4 receptor monoclonal antibodies. This ibalizumab, they are used as a IV therapy, as an induction therapy. Then they, after 7 days, they can go for this. Instead of 2000, they go for 800 milligram for 21 days. Yeah, and then maintenance every 2 weeks. So ibalizumab is one of the latest drugs which is used for the patients who have a highly ART experience, and most of the drugs are not working. That is the time ibalizumab is useful, but still it's not available in our country. The next strategy is two drug therapy. We know that there was no therapy or monotherapy. The rate of the death or the morbidity was same. When we had a two drug combination, the death rate of morbidity came down. And when we started triple drug therapy, there was a drastic reduction in the morbidity and mortality. So this is one of our patient. This patient, 50 years old patient, HIV-2. She was detected positive in 2008. And when she came in month of July 2015, she had a cough, loss of appetite, severe weakness. And she was on ART, tenofovir, FTC, boosted lopinavir. Patient didn't have any comorbidity like diabetes or hypertension. CD4 count was good. But when he investigated, we found she had a pulmonary cox, and in addition to that, she had albuminuria, sugar. So there were side effects of tenofovir. So we changed this patient to abacavir, but she developed hypersensitive abacavir in 2015. We didn't have this HLA 5701 testing. Now we do test before starting abacavir. So it was patient was switched to AZT, but develop severe anemia and nail discoloration, then change it to D40. Even D40 is certain time when other drugs are not available, it is definitely we can use it. But patient develop dyslipidemia due to lopinavir. So we switch it to atazanavir. We are thinking of switching this patient to darunavir, but patient could not afford, and patient developed neuritis to D40. Then such situation, what we'll do? So two drug therapy, and there were many paper initiation of two drug therapy, maintenance for purpose. So we started this patient on Dolucor 3TC in October 2017. And if you see today, this patient is still on D43TC with the CD4 count is 1130 and the virus load is undetectable. But in December 2019, we changed this patient to three drug combination. The reason being, two drug combination, how long it will work, we do not know. Because when he thought of the long term, and that's why we discussed with the patient, and the cost wise, there was hardly any difference because we could not give darunavir to this patient because of the cost. So we switched this patient on bictegravir, and patient is doing very well. So these are the indications where we need two drug combination as a initiation or the maintenance, both. And according to DHS guideline, this can be first line. So what are the conditions where you can use? For the simplification, comorbidity, avoid toxicity, and drug-drug interaction of pregnancy. So these are the conditions we can use this two drug combination. According to me, in our country, if you see that when you put patient two drug combination, adherence is a very important thing. People are not following good adherence. Please do not use two drug combination. It is very costly. Patient, at least they should be on ART and under control more than 6 months. There should not be any history of biological failure or HB infection or any resistance. So when you are used to drug combination, there are certain things we'll discuss in the. So these are many patients of mine, more than 3.5 years, they are on two drug combinations and they are doing very well. We do frequently virus load in this patient more than CD4 because you have to see there is no failure virology. Then selecting strategy, that is switching drug strategy. Switching drug strategy are almost same for the toxicity purpose, avoid a drug-drug interaction, morbidity, aging, or simplification, we can do it. For example, this is where there is a risk of cardio by using boosted PI, where the patient can be shifted to dolutegravir or bictegravir or INSTI. So we have new drugs in our armamentarium, that is darunavir, altegravir, dolutegravir, bictegravir, and TAP. So I just, because TAP is also important along with this, because many times you also, how the TAP is important, all of us know that the dose of the tap is very less compared to tenofovir, because you are facing lot of toxicity due to tenofovir, and because there are certain population, older people, menopausal, osteoporosis, where tenofovir is become the limitation. Yeah. So they said even there is a renal failure, you can give tap, only that creatinine clearance has to be more than 60. Then about the albuminuria or proteinuria, those patients were shifted from tenofovir to TAP, their albuminuria reduced. At the same times, their kidney functions or tubular functions parameters started improving. Same thing with the bone marrow density, with the hip and the spine. Both those patients who were a TAP were the boosted boosted PI compared to NNRTI. This TAP has got more more ability to create this osteoporosis. So about the tenofovir, they are compared with the tenofovir TAP. They are compared with the tenofovir, and what they found, the patients who are on the TAP and boosted PI have maximum chances of going to renal failure or the renal problem compared to NNRTI, either efavirenz or nevirapine. So when you are using tenofovir, we have to bother about this. All of us, we are aware of that. Then coming to about the pre-exposure tap can be used. These are the study where we can use it. Now talking about dolutegravir. When you're talking dolutegravir is well accepted as a first line or for the initiation for the first line failure or second line failure. So dolutegravir is one of the very good drugs, is a very potent drugs, is started using all over. In fact, in our India now it is available at the government program. So the problem was about the neural defect. When they were thinking of neural defect, now WHO says Daludo can be preferred in the treatment in all options, that is including pregnancy. Only thing during pregnancy they say that you must explain to the patient this is the possibility, and they said as far as possible, first 14 week of pregnancy better to avoid this drug. Of course, DTG has got a lot of limitation, weight gain, pregnancy, adverse effects, and in pregnancy there are chances of premature delivery, small gestational age, spontaneous abortion, but this is very less. These are the things. Weight gain they have compared with the bictegravir and dolutegravir, and they found those patients were bictegravir and dolutegravir, they started getting weight gain. They have compared with the all other like INSTI, PI and the TAP, and they found even the TAP is also responsible, not only INSTI, they are also responsible for the weight gain. They compare with the men and women. They say the men after certain period the weight gain become constant, but women it keep on increasing. These are the studies. But I do not know. In my clinic, this is our observation. Some of the patients, they now one of the patient on dolutegravir weight was 66, it became 104 kg, and we shifted this patient on bictegravir, and today the weight is 95 kg. Same thing. These are all these patients, they are on dolutegravir. We shifted them on bictegravir, but it is quite surprising. But these are the observation in my clinic. We have shifted more than 8 months, and there is reduction in the weight. Those patients had high weight or they had weight gain, 99 kg, 80 kg. Those patients, they have reduced the weight. Yeah. Talking about bictegravir, another robust antiretroviral. Again, this can be used anywhere as a first line therapy, maintenance therapy, second line or third line therapy. It is one of the very good drugs. Yeah, it can be used first line, second line, or third line. Of course, Dolutegravir has got many advantage. It has got single tablet, small tablet. There are hardly any restrictions, food restrictions, or low viral load, or low CD4, nothing like that can be given. Only thing eGFR should be at least 30, and it can be given in hepatic impairment, is non-inferior, non-inpatient and switch population, no in restriction of hepatitis B or hepatitis C. So this is one of the wonderful drugs. Only in the example of these drugs, yeah, when you're using it now, the diabetes is very common in our country. So using metformin, they said we have to be very careful. We have to, in bictegravir, no adjustment of metformin is required. But in dolutegravir, because there are chances that patient may go into hypoglycemia, so we require the adjustment of metformin. When you come into drug-drug interaction, the raltegravir is the drug which has got minimum drug-drug interaction. So when you are suspecting, better to use raltegravir. So these are my patients for last 1 year. They are on bictegravir. They are doing very well. Then coming to darunavir. Darunavir is another wonderful drugs, but they said when you're using darunavir, again first line or the second line, third line, what is important, genotype testing should be done. That is very important. So before starting, ideally, you should do genotype testing before starting darunavir. Initially, they thought darunavir is responsible for weight gain, but then they found the people were on the TAP and darunavir. They found it was due to TAP. So about HIV and COVID, we know we are treating this patient, but they say the mortality in HIV is due to because the underlying burden of risk factor like diabetes, obesity, kidney problem, chronic kidney problem, or the lung disease, not only HIV. So these are the, I thought I'll just give introduction about these various drugs, and now we'll switch over to panelists. So we'll start with the panelists. I think Dr. Gilada, are you ready? Dr. Gilada?
Yeah. Good.
Yeah. So we'll start with the first questions because now everywhere they're talking about this ending of the HIV epidemics. So Vinaya, so can you elaborate what is the meaning?
You see, the Millennium Development Goal, they would like to end HIV epidemic by 2030. And by 2025, they would like to have 95, 95, 95. And 2020, it was 90, 90, 90. But what we have seen is like a man proposes, God disposes. COVID came in 2020, so that 2020 deadline of 1990 is unachievable. In any case, it was not to be achieved because we are not going wholeheartedly on that. However, with 1990, if we cannot achieve by 2020 or 21 or 22,
Yeah.
all other deadline will be postponed.
Yes.
What they would like to do by 2030, that they would like to have a zero death because of HIV. And that is possible that HIV related death can be zero. Whosoever dies in amongst HIV patient, they may be dying of some other complications, including metabolic complications, but not by HIV per se. Second thing is zero new infection. I doubt very much zero new infection can be achieved. What can be achieved is zero new infection from blood transfusion, which is already very close to zero infection. But if they introduce newer test for screening in blood banks, that can be done. So PCR, you see, our country could do crores of PCR in or RT-PCR in COVID patient. I don't know why PCR was not introduced in screening of blood bank. There they said cost is very high. So I don't think cost could be a problem in our country. So that can be made zero if we introduce PCR testing in blood banking. And in PCR testing in blood banking, they can also pool 5 or 10 samples, and that can be reduced. They can be nucleic acid test, NAT test also. Secondly, we can have zero transmission from mother to child. In private sector, we have been seeing that this is possible. Possibly in government sector also, they can achieve, provided the uptake is good. Currently, what is happening in pregnancy clinics, is that a lot of women do not come back for testing, or they come very late. By that time, they do not decide, or they are not able to give ART at least couple of weeks. If you give dolutegravir or bacterial-based ART, even for couple of weeks, the viral load can become undetected.
Undetectable, yeah.
So these two are possible, but sexual transmission, making it to zero is very difficult. Till our country has not approved PrEP officially. PrEP, private practitioners are practicing, but it is not available in public sector. So, and we see in MSM population, a lot of sexual activity is still going on, despite whatever awareness has been created. So unless until PrEP, PEP, they become very much amenable to people, I don't think we can achieve zero transmission from sexual transmission. So basically, is unachievable target. But we also see new patients have come down, but earlier patients are not dying; they are surviving longer. So growth rate in clinics of the practice is maintained. It is not very high, but it is maintained. Growth rate is there.
Thank you, Dr. Gilada, for bringing out what are our challenges or what are our limitations. But the next question I'm asking you, where we are standing, where India is standing in this 1990?
See, in 1990, what happens is when we hear 1990, we think that only 10% is reduced. It's not so. It's 90% of 90% is 81%, 90% of 81% is 72%. So even if we achieve the target of 90, we are still at 72% in total gain. And that is not even a mark of 75%, which we call a very good mark. Secondly, in the first 90, where out of people who have HIV, 90% people should know their status. Currently, the government of India has estimated 21.4 million infections, out of which 15 million people know their status. So still 6 million is a wide gap, almost is a almost 23%, 24% gap. Amongst the people who are already knowing their status, still there is a gap of almost 20%. 80% people are on treatment. And amongst the last 90, where viral is suppressed, government of India has started viral load screening 1.5 year back. So till today, they are not able to say how many people could be virally suppressed, but some of the data what they shared was around 85 to 90% people are suppressed. So
Oh, that's very good. Yeah.
we are in third 90 we are achieving good, but in the first and second 90 we are lagging behind. And first 90 is not going to be achieved because our entire efforts of prevention or awareness, they have gone down. If you talk to any CBOs or NGOs, their activities have gone down. So or they are not getting any grants. If you cut the prevention efforts, if you just go and focus only on treatment efforts, then the prevention efforts will be lax and new infection cases will keep on coming. And at the same time, you are not able to put all of them on treatment for several reasons. That remains a gap.
Okay. Yeah. Yeah. Thank you very much. We'll go for the second question. Second question is, Doctor, with all the newer molecules available, what are the basic precaution we should take before prescribing? So I'll ask Dr. Dinakar.
Yeah, thank you, sir.
Yeah.
Yeah, I think in one of your slides you did mention, although initiating treatment on the very first day, test and treat approach,
Yes.
we should definitely be mindful of the fact that we should start treatment when the patient and the family is ready.
Yes, correct.
No point in going overboard for everybody and be in a great hurry to start.
Yes.
Having said that, now we have single treatment regimens, harmonized treatment, perhaps if you can call it, and slowly the efavirenz will probably lose its position, and therefore we don't really need to worry about side effects, especially we are using the fixed drug combination of big T, TAF and FTC.
Yeah.
So side effect profile is not really much of an issue these days. Yeah, we should make people aware of weight gain problems with DTG.
Yeah.
Particularly, we are treating a lot of 50 plus patients with comorbidities. So we should sensitize them for that. But yeah, I think now regimens pretty simplified. No need to unnecessarily probe into too many options. We have very good options of INSTI based single pill regimens, and that's what we should stick to in most patients. except as you rightly mentioned earlier in your talk about in pregnancy, maybe neural tube may be an issue. And of course, people with co-infection, we don't have data of using rifampicin with these INSTIs. Though with dolutegravir, they say we can double it, but then the cost keeps going up. So I think except for those two situations, we need don't have to worry too much about it. And we again, as far as administration of drug is concerned, not much linkage with the food or without food doesn't matter. So adherence definitely will not be a much of a challenge. But yeah, if you're introducing the drug first time for anybody, it's a lifelong treatment that has to be impressed upon. Otherwise, co-infections, hepatitis B, as the slide says, also it can resist. So by and large, it's in fact somebody said HIV treatment has become boring now. It's become so easy. And what I'm pained to see is the current generation of postgraduates. I think that must be your experience also. They are not interested.
Yeah, they are not correct. Yeah, the new
And
generation.
that is a very painful observation which I have found. Once upon a time in the theory paper, at least one question used to be there on HIV. Today, that has also disappeared. So generally, that interest somehow has waned. The same set of 25 people or 30 people who have been meeting each other for the last 2 decades are continue to take care of these patients. So, but I will definitely like to see that some interest kindled among the newer generation which is coming out, so the drugs are handled properly.
Yes, correct. I agree with you, Dr. Dinapar. I remember the national conferences, the number of delegates is 20,000, 15,000. But
Yes.
when the topic of HIV comes, there are not 30 to 40 people, there are hardly any 30 to 40 people. So as you said, many clinicians, they have lost their interest, but we have to see that we can sensitize them again, because this is the national issue, is a community issue. Just practicing is not the issue, because you have to think of community also, no?
Yes.
Of course, there are, as yeah, Dr. Dinakar has said, other like a toxicity, adherence should be taken also in the consideration. So the next questions I'll ask Dr. Pujari, that they said first test and then treat. Previously it was wait and watch. So what is change in your practice? How you have adopted in your practice?
I think the data is very clear. The START study has very clearly shown that early initiation of antiretroviral therapy is capable of reducing not only AIDS-related but non-AIDS-related events as well, including some issues of bacterial pneumonia and all those things. So the issue is not about science. Science is very clear. You need to initiate as early as possible, as soon as the diagnosis is done. The issue is more structural and on an individual basis, affordability and all those things. Even that is less of an issue nowadays. If, for example, a patient can't afford treatment, we don't hesitate the patient to refer to the free program, because continuation, what we call as ART persistence, is very, very important. And I guess most of the patients would initiate treatment as soon as a diagnosis is done. There are now randomized trials also. I think you showed a meta-analysis looking at various trials of early initiating ART or rapid initiation. And they have definitely shown to be effective even in the long term when you compare them versus patients who initiated later. Yeah, so as you see here, the ART within 90 days, retention in care or viral suppression at 12 months, all of these relative risks favor really same day ART. So I think it's a non-issue really. We need to be able to motivate our patients to initiate ART and as soon as possible, both from the personal benefit as well as transmission benefit, because
Yes,
we know
correct.
that
That's
we are
right.
able to
Yeah.
reduce the risk of further transmission of HIV. And I think it's a non-issue really. You need
Yeah.
to really.
Yeah, so Dr. Pujari has given very loud and clear message that test and treat has to be inculcated in our practice. There is no any other issue, but what we need is a awareness program, and this information has to go, and this definitely helps in reducing the viral reservoir. So it helps in the spreading of the disease or controlling the disease. Yeah, we'll go for the next question again. Dr. Pujari, I'll ask you only, what should be the ideal sequencing of darunavir, bictegravir, and dolutegravir?
Yeah, so at this point of time, I think we are talking about ARV naive patients starting from that
Yes,
stage.
correct. That's
We
right. Yeah.
see all of us have seen a reduction in the naive population coming to us. Most of the patients who come to us maybe in our practices, but we do often see some patients coming to us who may have lost to follow up in the initial time periods, who were initially diagnosed and then subsequently were keeping well and now coming with problems. So apart from that, naive population actually is coming down. Patients are already on ART. Most of them are doing well on, say, TDF, 3TC, efavirenz, either 600 or 400. That's a major regimen we have been using for the last decade or so. And these are suppressed patients doing well. For a truly naive patients, I think again it's a non-issue that INSTI-based regimens have proven to be either non-inferior or superior to an NNRTI like an efavirenz-based regimen. And there is no head-to-head comparison, interestingly, for naive patients between INSTIs and boosted protease inhibitors. But I think essentially it's not needed, that trial kind of a thing, because boosted protease inhibitors are uh, you need to really keep them up for further sequencing. What is interesting is, of course, as you had shown in your slides, when you choose between bictegravir and dolutegravir, they are really head to head, except that maybe DTG can be used in twice daily with rifampicin, because that is something which is quite common in India, tuberculosis, and bictegravir PK data has not shown that it achieves good levels in spite of doubling the dose of bictegravir along with rifampicin. So that is definitely a negative point for bictegravir.
Yes,
Uh,
correct.
but the other issue is, of course, TAF in combination with the bictegravir, and TDF or TAF in combination with DTG. And as you have shown again, weight gain is an important issue with TAF as well. So you have to really monitor them for these weight gain, and we really don't know what are the long-term metabolic consequences of this, whether they cause type 2 diabetes, hypertension, cardiovascular risk. These are some of the things which are still unclear at this point of time. Having said that, I think we are moving to INSTIs have also been thought of as a best kind of a protection for transmitted NNRTI resistance. What is happening in the world, of course, because NNRTIs, including in India, have been used for a long period of time, there is a likelihood that people who are failing NNRTI are transmitting NNRTI, and there may be primary NNRTI resistance. And INSTIs may be able to cover for that, and that is the reason why they should be positioned as first line. But interestingly, there was a publication from the advanced study which showed that if you have primary resistance to 3TC or NNRTI in the advanced study, the DTG based regimen did not do well as compared to when you didn't have. So even that idea that primary NNRTI
Yes,
resistance,
yes.
that is the reason why you need to go to bictegravir or dolutegravir, is not really entirely true. But I think right now, starting with TAF slash TDF plus XTC plus either bictegravir or dolutegravir, depending upon
Yeah.
what the situation is. If the patient fails, that's more likely not to fail because of INSTI resistance, more likely either at 184V is likely in that situation. In the second line, maybe you can switch the NRTIs and put them on a boosted PI. And honestly, we have not seen much failures happening on the INSTI-based regimens.
Yeah, so Dr. Sanjay has covered it very well. What are his limitations and what are the drawbacks according to you select the drugs? Because you cannot say this is the drug you can use this. It depends upon the conditions. According to the conditions, and even according to this, even this DHS and EHS, that bictegravir and dolutegravir can be used as a first line therapy. Yeah. Next question is to Dr. Pradeep. Pradeep, the question is asked, a patient who has been in good or lamivudine, zidovudine, and efavirenz 600. So after reading, now there is a lot of information about the INSTI. So they want to know whether to continue the same combination when the patient is doing very well or changes to INSTI.
So thank you very much, sir. So to answer this question, see, first of all, he's on a lamivudine, zidovudine, and efavirenz. So he's actually have to take almost 3 pills a day. So there is a question of pill burden. Though he is not developed toxicity, it's not actually, they haven't actually mentioned the duration of zidovudine actually on the regimen. So though he has not had any short-term side effects with zidovudine, he can always have long-term toxicities like lipodystrophy or even hyperlactatemia and lactic acidosis that might set in much later, and hepatic steatosis. So to avoid that and to make the regimen simple, I would definitely like to move into a DTG-based regimen or a bictegravir-based regimen. So everybody has been talking about weight gain, weight gain, weight gain.
Yeah.
See, one of the latest thing that even talked about, published in CID in July 2020, where people were switching. I mean, it's a RCT switching bictegravir, emtricitabine to people who are virologically suppressed, along with DTG, and comparing them. And what they basically showed was people with bictegravir actually gained weight. The weight gain at the end of 48 weeks was about 1.3 kg with bictegravir versus 1.1 kg with DTG. I also listened to your point where you said that we don't see much, and I agree with you because I've actually, so into the mid of 2019, we analyzed patients from our data, and then we found almost most of the
I
people.
think Pradeep, weight gain will take in the next. There is the next question. So
Yes,
yeah.
but
So
I would
switch it.
definitely,
Yeah.
I would definitely like to
Yeah.
switch him to a
Yeah.
dolutegravir, and there is no
Yeah.
question of positioning these
Yeah.
drugs for
Oh,
later because they are also
yeah.
a high genetic barrier drugs as well, right?
Yeah. So according to you, there are a lot of advantage of switching toward the INSTI. The reason being, one is as the pill burden, number two, the side effects, and the controlling and chances of patient going into failure with the poor adherence. So there are many reasons we can switch over, but those patients where it's not available, of course, now in the government program is available. So according to the other, Dr. Pradeep, is better to switch. Correct, no, Pradeep?
Correct, sir. I agree
Yeah.
with you, sir.
Yeah.
Better to switch.
So of course, there are many reasons. They said because of toxicity, because of drug-drug interaction, you can change it even the drug is effective. Now the next question is I'm asking to Dr. Dinakar because he has worked in the metabolic syndrome. So Dr. Dinakar, can you elaborate on the DTC-induced obesity?
Yeah. Yeah, of course, this
Yeah.
has been sensitized right from the earliest trials with DTG, starting the advanced trial, etc. In our practice, yes, it's not been a very major issue, but we definitely need to sensitize our patients about the issue of weight gain. Why I am saying that in particular context is our age group of patients who are now on ART is typically 50 plus, 40 plus, and these people quite often have comorbidities like diabetes, hypertension, cardiovascular, dyslipidemia, etc. So weight gain is not just a simple cosmetic issue here. So weight gain could contribute to adverse effect on all these and may actually contribute to premature coronary artery disease, as we already seen from DAD studies. So, uh, so some of these patients, if they have comorbidities, of course, we are continuing the INSTI-based treatment. Quite a number of them, we have put them on prophylactic aspirin plus statin, though it's not a real strong recommendation as standard of care, but we've done that for several of our patients if they have comorbidities. So weight gain should not be looked at just a cosmetic problem. Discussing at the very beginning should help. Of course, we should emphasize lifestyle changes in the very beginning to counter the adverse effects of weight gain, and it has worked. There's nobody who has come. I mean, we have a good number of patients on INSTI-based treatment. Nobody's actually come back and insisted on going back because his weight gain has been, I mean, sort of unacceptable to him. So as you projected in your experience also, the weight gain has been modest. So it should not be such an issue that we actually have to move away from INSTI-based regimens merely on the basis of weight gain issues.
Yeah, but Dr. Dinakar, some of the patient get more than 100 kg. They go beyond 100 kg. Yeah. So,
Well, yeah, that's what I mean. Again, we may probably have to individualize.
yeah.
Apart from the unacceptably high weight gain, if this patient has the traditional cardiovascular risk factors, atherosclerotic risk factors, then we can consider shifting to a non-INSTI based regimens. But yeah, we need to weigh the risk and benefit of obesity along with the comorbidities before we decide to shift them onto non-INSTI based regimens.
Yeah, but even non-INSTI, what are the non-INSTI we can give them? Because some of the patient they're worried.
Correct. Then the cost issue comes up if you are going to shift them to the Darnavir, but we also have problems of dyslipidemia with the PI boosted. So there are, I mean, it's not an easy answer in terms of switching the therapy here. But really, we don't have much data about, I mean, early onset coronary artery disease just because of weight gain induced by either TAF or INSTI based regimens.
Yeah,
So we
because
need to have more data on that before we worry about it, like how we worried about Avacavir in the DAD study in terms of coronary artery disease.
yeah, because they said most of the drugs they are responsible for this. Even abacavir also, TAF
Yes.
is there, Rilpivirine there, doravirine. So many drugs are responsible for the weight gain. Correct? Even
Correct.
now they say
Yes.
cabotegravir is
Yes.
also is responsible for that. So I would like to ask all panelists, what is the percentage of patient put on dolutegravir or bictegravir, they go into weight gain? Dr. Gilada?
I think initially the weight gain is a status symbol. A lot of patients and their families come, doctor, you have done such a wonderful thing. Yes. So
Yeah.
I think, and they praise doctors that
Yes.
he was always losing weight, or he never had this kind of weight, but he got it. So there's a number one is a prestige symbol.
Sick patient, yeah, I agree.
Secondly, what we are seeing that initially they gain weight and later on they settle down. But thirdly, if we tell them in advance to increase their physical activity, exercises, etc., that is
Yes.
better. What we have found, there are two things I would like to share.
Yeah.
One is during the COVID period, uh, irrespective of DTG or even before if you count DTG, people have gained 3.5 to 4 kg weight on an average. Some people have gained 15 kg weight sitting at home. So weight gain is because of your habits also,
Correct.
what you are consuming, what you are exerting. Secondly, what we have also seen that efavirenz has also caused a lot of sexual dysfunction, and I have not seen many of these studies published. But among the patients, which when we inquire, there are a lot of sexual dysfunction among people who are on efavirenz for longer period. So, and as it is, a lot of doctors have told them to the couples that you don't have sexual activity, it will again retransmit a virus or different strains of virus. So, because of HIV, they already reduced sexual activity. I believe if you have to maintain weight and everything, there could be
Yeah. But what is the percentage of people on Insta? They develop or they gain the weight. What is
most
the
of the
percentage?
we started were switched from efavirenz, and that's what I told
Yeah.
that if you take average, almost 60 to 70% people have gained weight, and if you see after some time, out of them about 35%, 40% they stabilize their weight.
Yes.
Oh,
So
stabilize. Yeah. Okay.
4 kg, 5 kg that remained there, and that did not go up further.
Okay. Dr. Pradeep, in your practice?
Sir, what we found in our cohort was whatever sir said, sir, Gilada sir said. We also presented a poster in IDV. So we also saw an average weight gain of about 3 to 5 kgs, and we found that mostly happening, especially in the first 3 to 6 months. That's where we found the weight gain happening, and most of them stabilized. But about 10% of patients, 10 to 15% of patients continue to have an exponential weight gain even
Yeah,
after that.
it is correct.
And those were patients who were mainly on TAF-based regimens rather than TDF-based regimens. So that's something that we noticed in our cohort. But this is something that we've noticed with DTG. Not with, so far, we haven't analyzed the data with Bictegravir yet.
Okay, Dr. Sanjay, because this is a big issue, Yeah, about.
I can show my data if I can share the screen.
Yeah, I think I have to go then. I have to stop sharing, no?
Yeah.
1 second, huh? Yeah. Okay, please show.
Okay. Yeah, so this, if you can see, this is our cohort. This was pre-COVID. We now have around 1,200 patients. We are analyzing that data. This is data of around 411 patients. And this is the context of initiating DTG. Very few naive patients, as I've mentioned before, but mostly substituting from efavirenz, nevirapine, majority of them substituting from raltegravir because that was something which was used previously, and most of them substituting, very few on failure. And this is a concomitant nucleoside, and as you see here, majority of them on TAF, TDF, and a few of them on other, and a significant proportion also on atazanavir, ritonavir plus dolutegravir. And this is because we use it as an alternative second line or third line in these patients. And this is what you see. When you talk about weight gain, you can't be really very vague about it. First of all, you have to think about mean weight increase that is happening over a period of say 2 years. And of course, as you go down the follow-up period, you may see a less number of patients. But what you see here with the mean and 95% confidence intervals in absolute weight gain is around 3 to 5 kgs, as was mentioned by the previous speaker. But what is important is what is the percentage weight gain and what is the proportion of your patients having more than 4% or 7% weight gain from baseline. That is clinically significant. It's not the absolute weight gain that is significant. And if you see that in our cohort, about 57% of patients had more than 4% weight gain, and about 30 odd patients had 30% patients had more than 7% weight gain. Once you have 7% weight gain, you're going to be worried about it in terms of it. So it's around 1/3 of patients. What are the risk factors for this? This is some of the data from our cohort. Females usually have a higher risk than males. If you are an elderly more than 50 years, again, as compared to younger, in the younger population, actually, we saw a higher weight gain, which is there. In terms of CD4 count, if you have a higher CD4 count, you have a higher weight gain. If you are virologically suppressed or if you are virologically failing, switching DTG because of that, there is no difference. Now, this is crucial, whether you are combining DTG with TAF, TDF, or boosted protease inhibitor. What we found in this multiple regression analysis is that as compared to TDF versus TAF, with DTG, TAF is more riskier. As compared to TAF versus boosted protease inhibitor, again, TAF is more riskier. And as you compare PI with TDF, PI is more riskier. So the real conclusions here is that it is seen in Indian patients, but I don't think it is as commonly or as high kind of weight gain that you see in this Black African population, like the advanced study or the NAMSAL study where 8 kgs and 10 kgs, and they continue to have weight gain happening beyond 144 weeks because that data is available now. Risk factors for weight gain in India, if at all, when you talk about more than 4%, is female gender, concomitant TAF, or a boosted protease inhibitor. And this makes us wonder whether, and there is large amount of literature available there to suggest that whether TDF is protective. And that is the reason why I think we should stop thinking to move away from TDF as well. TDF is a nice drug if you use it unboosted. If you are going to use it with a boosted protease inhibitor, all these side effects that you're talking about, renal or bone, happen in that context. And there is a meta-analysis published in AIDS, which shows very clearly that TDF unboosted is same as TAF boosted or TAF unboosted in terms of side effects, in terms of efficacy. But when you boost TDF with atazanavir, ritonavir, with the boosted protease inhibitor, in that context, you see this side effect. So it's important also to think about
Sanjay, you mean the renal and the bone toxicity is more if it is a PI boosted with TDF? You want to say that?
Yes. So essentially, you see this in that context.
Okay. Yeah. Did you finish?
Yes.
Yeah. Okay. So I'll share my slide now. Yeah. See, but I do not know, my clinic we have kept the record, and as you said, more than 7. For example, person had 66 kg, he became 104 kg. Patient is 95, he became 170. So this is just not acceptable, but only 10%, not more than 10%. These people, and I do not know, we change it to Bictegravir with TAB. And you see, their weight has been reduced and they are maintaining it. I do not know, but these are our clinical observations. That's why I raised this question.
Can
So,
I just come in there?
yes,
The issue here is, this is again anecdotal,
yes.
and we also see sometimes 1 or 2 patients who may have a significant weight gain, which of the type that you're mentioning. But I showed you clearly the data. That's a data of around 400 patients. And that essentially shows a modest kind of weight gain. There is, of course, more than 7% seen in 30, and more than 10% maybe further lower. So that is one. Secondly, switching for weight gain from INSTI to non-INSTI has not shown to be beneficial. There is a study which looked at TAF, 3TC, DTG, weight gain, stopping TAF, no benefit. So switching doesn't benefit. And in your context, you're switching from DTG with backbone nucleoside, switching to TAF,
Yes.
which is associated with weight gain, and you are saying that it is causing weight
Yeah,
loss.
that's why I'm wondering. That's why I'm wondering. Which is, because if you go by the literature, this is not acceptable at all. Whatever the literature is available, no? But this is the fact.
Yeah, sir, you should publish it.
Yeah, that's why. Yeah, thank you. I may need your help. Yeah. So we'll go for the next question to Dr. Pradeep. It has been observed that the low dose darunavir has CNS escape, where the patient viral load is 793. Sorry, CD4 is 793. Virus load is undetectable. Landed with the CNS complex. Why? They ask why. Why this is happening?
You repeat it, sir. I didn't get the first
patient
part.
is on a low dose of darunavir. Low dose of darunavir.
Okay.
Coming with the CNS complaint, in spite of his virus load is under control, undetectable, and CD4 count is very good.
Yeah, but it could be, have they done any CSF analysis or an MRI to see what is happening in the brain, or what is the neurological symptoms that he has?
Yes. Yeah, so is the compartmentalization? Yeah, correct.
Yes. Yeah. So it could be a compartmentalization. So probably I would recommend getting an MRI done and a CSF studies done, and as well as a CSF viral load done. And if there is a thing, and then get a genotyping done also in the CSF. We have seen people with suppressed viral load, but mutations, both PI as well as NRTA and NNRTA mutations in the CSF as well. So when they have had a suppressed plasma viral load in our cohort as well, sir.
Yeah.
So I'd ask them to do that.
Yeah. So ideally, when you are using darunavir, I think better to do genotyping and start. When you are starting the low dose, the adherence, we have to see that there is no history of any resistance, virological failure. Those are things are very important when you're starting with the low dose.
Dr. Sapai, low dose means what dose?
No, what they mean.
OD dose. I think he's talking about OD dose, sir. I
What
think
they
it's
mean is
about
OD
800.
dose, not BID.
Yeah.
OD dose. Yeah.
Yeah, 800 milligrams.
Yeah, 800 milligrams. Correct. That's right.
Yeah, so can I come here again? There is a CSF
Backbone you are giving, that also
concentration
matters.
study.
Yeah.
Sorry.
Whether CNS penetrating backbone is there or not, that also matters.
Yeah,
So
so
you're
the whole,
probably on a TDF containing regimen with that, sir. I don't think that is, so you're only Darna with 600, 100 is shown to have good CSF penetration with a score of 4. OD dose doesn't have as good as CSF penetration score as the BD dose.
Yeah, Sanjay, you want to add?
yeah, the whole concept of CNS penetration is being looked into again. What is the concentration of drugs in the CSF and all those things are really not as valid today as it was some years ago. Things like, you need to really look at intracellular concentration in the brain parenchyma and things like that. So these are not really very linked. If you look at the latest CP score, which was, I think, published in 2019, that after that, I couldn't find any reference for that. Darunavir, Ritonavir has a CP score of 3. That is reasonably good. Dolutegravir has 4. Incidentally, both TDF and TAF have a CSCP score of only 1. So it has the lowest CP score. So it is a CP score of the regimen, and there is also resistance. You need to account for mutations also, compartmentalized mutations. So it's a complicated thing. Just switching a regimen is, as was mentioned by Pradeep, I think you need to clinically evaluate this patient properly and then really look for whether changing a regimen is going to make an impact.
Okay. So we'll go for next question. This is for Dr. Dinakar. What is your peak compared to DTG and BIC?
Sorry, I didn't get the question.
No, which you will prefer, dolutegravir or bictegravir?
Well, very frankly, as a initial therapy, nothing much to choose. Both are available as fixed drug
Yes.
combinations.
Yes.
Dolu was launched a little earlier, so we have little more experience with Dolu.
Yeah.
Of course, since we are talking about 2 drug regimens, Big T is still not available
Yeah.
as a separate pill.
Available. Yeah.
Yeah, that is one probably the issue. But really, as far as I am concerned, not much to choose between the two. Those studies have shown little more weight gain with the Dolu compared to Big T, but overall, nothing much to choose, I guess.
Okay, this is already, I think Dr. Sanjay has elaborated in the past question, but depend upon the situation, according to situation, you can select. As I said, for example, if it is a tuberculosis, dolutegravir drug of choice. If it is a diabetes, I'll prefer bictegravir. Like that depends upon the situation. So we'll go for the next question.
I mean, one more special situation is pregnancy. There is no data for use of bictegravir in pregnancy.
Yeah, bictegravir, no data.
And the neural tube defects, there was this SEPAMO study, which was recently also in the last IS virtual. They presented the latest data. As the observation period increases, the frequency of NTDs, neural tube defects, goes down. It was initially 0.3, now it is 0.1. And it is same as with any other antiretroviral drug, periconceptional use, but it is a little higher than the general HIV negative pregnancy.
0.3 and 1, correct. That's, yeah. So with the explaining to the patient, you explain to the patient and you can use dolutegravir, correct? But bictegravir TAP, we do not have data. So now the next question is to Dr. Pradeep. Pradeep, they have asked, now we are talking about all this INSTI. So what will happen to efavirenz and nevirapine, NNRTI? Do you think we are going to forget them?
I think with INSTIs coming in, I think it's time. I think they've had a good run. I think we have to move with science, and science has clearly shown that INSTIs are much better on the long run. And we are talking about people living as good as HIV negative patients. So I think it's time we have to move past, efavirenz as well as nevirapine, both.
Yeah.
Probably HIV, TB co-infection, we still need to preserve efavirenz because we have.
Yeah, in our country, that is, as Dr. Dinakar said, that is a very important point. because you are dealing with the opportunity infection. Tuberculosis is the main opportunity infection where the efavirenz is, of course, those drugs are still useful, but when you talk as Dr. Gilada, what is your opinion?
I
Dr.
think
Gilada?
we should not take out any drug from the platter. We should preserve them. Nevirapine has very little role. There are instances where people have watched by nevirapine. They've been using for 10, 15 years, no problem, but they're very, very rare. So efavirenz is still a good drug, but better in 400 milligram dose rather than 600 milligram dose. If we also take care of DTG in tuberculosis with low weight people, I have tried because they could not afford double dose of DTG, and we kept on the same dose of DTG. There was no problem. They were virally suppressed after 6 months. So only when there's a weight is more than 50 or 60 kg, that time we have to think of double dosing. In such situation where people can afford, I think Raltec
That's
is
it.
better than all other INSTI drugs. So there's a definitely
So the
role
message, yeah,
role for INSTI,
yeah.
and other thing will remain in cupboard, but they should not be shelved off. Like we have ticked off Indinavir, where we still need Indinavir for CNS CNS,
Penetration.
and we are not having that kind of thing. I have seen people getting worse and worse because of loss of Indinavir. So we should not think of any drug.
No,
Sir, when I said that we should move past, I didn't say we should scrap them out. So that's not what I meant. What I meant was we should
I
move
know.
ahead
You
with
prefer
the,
this. Yeah,
yeah.
agree. So all those old drugs, for example, 3 patients of mine, the other drugs are not acceptable to them. So I'm putting on depot T because the survival is more important than your disfigurement, no? Anyway, because that is the only thing is there. Yeah. So we'll go for the next presentation. Yeah. This is one of my patient 50. This is for all panelists. 50-year-old male
Need
patient.
to share your screen, sir.
Pardon?
Screen share.
Is not sharing?
No.
Let's see. Bharat, can you help me? Bharat, I think who is a technical person? Hello? Hello?
Hello, sir. This is Srinivas, sir. Sir, tell me, sir.
Srinivas, how to bring the slides back to the presentation?
So once click the share screen button, sir.
Yeah, but where, yeah.
At the bottom.
Where is that share screen?
If you take your cursor below, there's a green screen which says share the screen.
Yeah, but I'm not able to see that.
Participant chat and share screen.
Yeah, I'm not able to see that. That's what, yeah.
No, you bring your cursor below.
Yeah, cursor is at the bottom only. Yeah.
Maybe you exit the full screen, sir. Exit
Okay,
the full screen, then you may see it.
I think your bottom is defected.
Yeah. Yeah, okay. I'm the sharing my, yeah.
Okay.
Now sharing, okay?
Yeah.
Okay, that's okay.
Yes, sir. Okay, sir.
Yes.
Slideshow from this.
Also bring it in slide presentation mode. Yeah. So
Yeah. See, this is 50-year-old male patient diagnosed HIV 2014, asymptomatic, no comorbidity. This patient, no history of pox, blood transfusion 96, known MSM, CD4 2001, plasma viral is 1,70,000. He was started with tenofovir, FTC, and efavirenz. In 2014, in the month of November, his CD4 count is good, virus load is under control, immunological, virologically is doing very well. But he came in 2016, where CD4 count was 439, viral load was less than 20, patient developed CD4 induced nephropathy, hence we changed it to abacavir. His HLA-B57 was negative. But then patient doing well, so serum creatinine normal except dyslipidemia due to efavirenz. So we switch to dolutegravir, abacavir, and instead of efavirenz. In 2019, patient is asymptomatic except weight gain. The patient came for the weight gain, but we switched to bictegravir, and of course the patient he is doing very well. But this I'll go for the next presentation. I think next is See, this is the yeah. This is 26-year-old woman diagnosed with the HIV 10 years ago. After presenting with PCP, CD4 cell count 34, virus load was very high, responded to PCP, started efavirenz, FTC, and tenofovir. On and off, the patient was adherence was not good. On and off, patient stopped and restarted therapy 18 months ago with darunavir, boosted darunavir based regimen. Recently moved to town with no records available. Currently, darunavir, cobistate, FTC, and TAP. This is picked up from one of the presentation. Stable suppression over 12 months, but complain of mild GI symptom. CD4 cell count is 290, virus load is under control. She is interested in a new regimen that is simple to take, but that might not cause GI symptoms. So this is the patient where they need switch. We have to switch. The question is switch. So when you are switching, here the patient is on darunavir. So which drug would like to switch? Dr. Sanjay?
So was the patient on TAF, is it?
No, darunavir. Yeah, boosted darunavir with the best regimens means, but that time I think TAP was not available. It must be.
No, it is TAF, FTC, COVID, darunavir.
Yeah, Cobistat. Okay. Yeah.
Yeah, because though COVID is not available in India, but this is obviously a case from the US or Europe.
Yeah, but then.
But the issue here is when we in India see this kind of a situation, we should also assume that GI disturbances may be secondary to TDF also, because TDF can cause a lot of GI disturbances. They're not just PIs. So of course, in this situation, it looks like the PI. Now this patient has been suppressed for how long, I'm not really sure. But and with the past history, she should have a 184V in her, may or may not have a TDF, but she is suppressed with the boosted protease inhibitor in spite of a TDF resistance. I think TAF, FTC, DTG may work for her, because in presence of underlying resistance to 184V, you may still see activity for DTG. There is one study also looking at bictegravir in archived resistance. So if a patient is suppressed, you may try and look at, with close monitoring of viral load, shifting them to either preferably DTG or a bictegravir based regimen. Yeah.
So there are many studies. One of the this study says you can switch over to bictegravir single regimen tablets. Even the patient is on boosted PI, whether is on dolutegravir, L-vitagravir, can be shifted to bictegravir. There is another study when they said where there is underlying resistance, resistance to. They said switching over from raltegravir to lopinavir is a better one when you are switching. And they said when you're switching from the same class, within the class, you can switch from dolutegravir to bictegravir. These are the various studies are there. Again, they said when there is an underlying resistance to NNRTI, NRTI, PI, better to switch to bictegravir. So most of the study, they suggest better to switch to bictegravir when they are suspecting NNRTI or NRTI resistance. Yeah, virological failure. So the question is, as you said, you would like to switch on to any INSTI, even bictegravir or dolutegravir. Dr. Dinakar, what about you? Because there are many choices.
Yeah, I think since the patient is looking for a simplified, effective regimen,
Yes, correct.
number C seems to be the most likely.
Hmm.
Two drug, I probably will not like to do it at this stage because we don't have duration of biological separation here. She's lost to follow up and suddenly she comes up. So I think the option C seems to be the most effective simplified regimen for this patient.
Dr. Gilada? Yeah. Oh, Dr. Gilada?
I think B or C, both will do.
Okay. Switch to Bictegravir or Dolutegravir, B or C. Dr. Pradeep?
Will also do B or C, sir. I don't have a preference.
Okay.
B or C.
So, yeah, okay, because because there is a poor adherence, so we cannot, this patient is known for the poor adherence or is not good adherence, where the switching to two drug is out of question.
Yes.
So, and these are the available, yeah. So, I think we'll stop it here because there are many questions, but we'll stop it here. Vijay, there are any other questions? Otherwise, Vijay?
Yes, sir. I can. Sir, we need to check with IT if the questions have come on the separate online query box. Anjanelu, are there any questions in the query box?
Yeah, Vijayji, this is Srinivas.
Yeah, Srinivas.
Vijayji, all
any
questions
question?
I will share to doctor's WhatsApp.
Yeah, but you have not sent it to me. I'm busy now. Yeah, please send it. Vijay,
Yes, sir.
no, did you send the question?
The question on WhatsApp to you.
Yeah, but it has come through whom?
So it has been sent to you on WhatsApp. I have shared your number with the IT team. They have sent you on WhatsApp.
On your phone.
You asked on WhatsApp, na sir?
Yeah, but which number it has come? Because there is.
Unknown number, no?
No, but how will I know the questions have come from which WhatsApp I should open?
No, but there must be only one WhatsApp number who is sending you question. All others are not sending questions.
No, but yeah, that's why I'm looking for that.
Check unknown number.
Yeah, unknown number only. There are two unknown number.
And I read only HIV related questions, not.
No, because it should be unknown number, as you said.
Yeah. You read out. Now somebody should read out the question.
Yeah, okay. Yeah, I got it. I'll ask Dr. Gilada only. What is the line of treatment in the post-COVID-19 fungal infection and how many days?
Fungal infection.
Yeah.
Which fungal infection?
I think this is another unknown number has come. That
is your dermatology.
Yeah. Because I should get an unknown number. No, Vijay. Otherwise, tell me that number. I'll write that number. Srinivas.
There is a question in the chat box.
Yeah. That's what I was about to say.
There is a question in the chat box, sir.
But we decided you will send on this. Anyway, we decided. Anyway, what is the line of treatment for same thing? Question is there. Dr. Gilada, the question: what is the line of treatment in post-COVID-19 fungal infection?
I think.
And how many days? This question I think I'll answer. Okay. See, I have seen many patients who are put on now this dexamethasone therapy after this Oxford trial, this research. Those patients who are put on steroid more than 6 weeks or 2 months, they are coming with a lot of dermatophytal infection. They are coming only, I see 5 patients with reactivation of sacral herpes simplex virus, just like what we used to see in the AIDS patient. So of course, this patient, this is because the steroid, they're taking steroid for long term. As Dr. Dinakar said, we should give for a short time. The long-term steroid will create, because COVID brings down their immunity, and again you are giving steroid. So definitely there will be fungal infection or their reactivation or even tuberculosis, as Dr. Dinakar has already mentioned. So we'll go for the next question. Question is from Dr. Sudhakar. I'll ask Dr. Sanjay, what is the latest molecule in the market?
Yeah, so which market? Indian market?
It's a captive market.
Black market.
Indian market latest, I think, is TAF FTC Bictegravir. I don't think something else has come. But internationally, I think
Yeah.
Ibalizumab is.
Yeah, can you mention internationally, because that will be, they will
Yeah,
be
so internationally, Ibalizumab is already approved for MDR HIV. If you're able to construct a backbone along, you obviously can't use it as monotherapy. And recently, US FDA also approved for Stemsavir. These are the two newer molecules which are being available in international market.
I think we should give a message to hetero, because they have got so many biologicals. So this, I think Ibalizumab, they should get it. Correct, no? This will be required, no? With the
we are in fact evaluating, sir, Ibalizumab.
Very good, very good, very good, very
from
good.
our biologic facility.
Yeah. Next question is from Dr. Sachin Kore from Solapur. Dermatology curriculum, 1 semester paper on STD and HIV. I think this, Dr. Gilada, I think this type of things, I think you should take up, no? Of course, all of us we should take up.
But no, see, currently what has happened after the introduction of INSTI, HIV is like a dying faculty. And people who used to come every 3 months, every 6 months, they are coming only after a year or so. A lot of people who could not come during the COVID, they are coming after 1.5 years. Still, they are doing well. So what will happen is there will be nobody interested, as Dr. Dinakar said initially, nobody would be interested as a full-time practitioner in HIV. So we need to increase the interest of people by having HIV and infectious diseases, HIV and other viral diseases. We have to decide or debate what kind of disease can be combined with HIV. Only then the faculty or only then the interest will survive and we can attract more people. Purely for HIV, I don't think there will be no new takers.
Yeah, I think that is becoming now as a, but you know, as you said, even now the new dermatologists, they are not able to diagnose leprosy.
Yeah.
So they have gone away. The same thing happened to the leprosy. Nobody is interested in leprosy. Now the same thing is happening with the STDs. So leprosy, STD and HIV. So these are the things are becoming now neglected. Now the next question is from Dr. Milind Kulkarni. Is there any data on TAP, FTC and Bictegravir in TB patient? I think.
You have already answered.
Pardon? No. No. Is there any data? There must be something, but at least I'm not aware. Any Sanjay, are you aware of that?
Yeah, so there's only one PK data, which was, I think, presented at CROI 2018, which was not published. That looked at TAF FTC Bictegravir BID with concomitant rifampicin and measured Bictegravir levels. And they, in spite of doubling the dose of Bictegravir, did not find it achieving EC90 for the wild type virus. Because of this negative PK study, I don't think clinical studies have ever started on this, because it is something.
So even doubling the dose. So Milind, thank you for asking this question. This is a very good question, because many of our clinicians may start with rifampicin and Bictegravir. Of course, not. They may. Yeah. Yes. Is there any other question, Srinivas?
Sir, no, sir.
Then I think shall I hand over mic to Mr. Nehru? And thank you all, Dr. Gilada, Dr. Sanjay, Dr. Dinakar, and Dr. Pradeep. We had a very good discussion. Thank you. Yeah.
Thank you very much, sir.
Thank you, sir. Thanks a lot. I think there's been a to have among our panelists. Uh, the verdict is clear. I think INSTIs should be the preferred choice when it comes to the treatment of patients. And as has been summarized by our panelists, they're going to help us in managing the patients, even if there is an NRTA cross resistance. And also, as the panelists have highlighted, the dosing is so simple that the patients, I mean, HIV positive people can live as normal as a non HIV positive person. So I think that's a wonderful thing that we are looking forward to, providing a good quality of life for HIV positive people. I think overall it's been a very positive outcome after our interaction. I think we shall continue with having a few more such interactions in the coming months as well, in order to check what are the newer things that are coming up with integrase inhibitor based regimens. Definitely, Hetero as a company has been working on other molecules as well. Evoluzumab definitely has come to our thought, considering our strengths in biologics. But we also need to look at the viability and the commercial aspect of evoluzumab. But again, I would say that when HIV treatment has started, we only had zidovudine, and zidovudine is given as IV, and it is like coming the life full circle again, going back to IV of evoluzumab. So, I mean, we don't want to get into that level, considering the complications that are associated with IV treatment. But overall, I think with the current treatment regimens as well, we can manage and ensure that the life can be prolonged for our HIV positive people, and make them live a good normal life. With that, I thank all the panelists, and I thank our moderator. Thank you very much, sir, for joining us. And with this, we'll close this session, sir.
So before you close, I just want to acknowledge
Yeah.
the local Hetero team led by Guru Prasad. At the peak of the lockdown, when there was not even courier available, they have personally somehow made sure the drugs reach the patients. Because several of them were calling and say, what to do, drugs have got exhausted, there's no courier. So they have personally gone and actually delivered and made sure there's no break in treatment. So that was a very good gesture on part of Guru Prasad and his team. I would like to acknowledge that.
No, that's really good service. Good.
And same thing in Mumbai also.
Right.
Sanjay and Sunil Shetty have done wonderful job, irrespective of what company drug they are delivering, or they seen to it that people get the drug, they are not dropouts. So I think heads up to Retro for this. Thank you.
Yeah.
Thank you, sir. Thank you for acknowledging their efforts.
Okay then.
Okay.
Okay.
Thank you, sir.
Good night. Good night,
night.
everybody.
Thank you. Good night. Good night, everyone.
Thank you.